Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. The Trust is pleased to once again partner with Drs. Margot Adams-Larson and Sarah Smucker-Barnwell to present these telehealth community chats. In the interest of time, we've placed their bios on a slide for you. This virtual webinar will earn you 1 CE credit. This can be combined with 5 other Trust continuing education credits to save up to 15% on your Trust-sponsored professional liability insurance policy. As always, please remember to submit your CE certificates with your policy renewal. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Thank you so much, Dr. Martin, and thank you to the Trust for having us, and thank you to everyone who's come today. Margot, it's good to see you again.
It's always a pleasure. This is the best part of my every couple weeks, so I'm glad to be here.
Bi-monthly highlight. We always like to start off disclosing those conflicts of interest, notably that each of us in our own right offers telehealth training. So this is something we do professionally, and in as much as that's the case, I suppose we have a horse in the race of telehealth. We want it to be successful, we want it to be democratized, and this is also related to the fact that we are unabashed telehealth enthusiasts. You know, you will find us really committed to the idea that this technology offers us a path to improving care access to populations who might not receive it otherwise. I think this is really at the heart of telehealth and its mission. And of course, anytime you give a presentation about technology, something technological will fail in a sort of sentient effort to shame you. So we like to disclose that at the beginning of our presentations.
And we own it. So I guess just to review for those who have been on and welcome those who are new, hearing from other colleagues. We're glad you're here. This is the bi-monthly check-in on how things are going in the world of telehealth and building this kind of community chat about ideas related to practice guidance in telepsychology, clinical concerns that come up for folks as they're traversing this path into the world of telepractice and telepsychology, and also the regulatory environment, which is ever changing these days. It used to be changing on an ongoing basis, but it's very much more rapid these days related to COVID and a number of other circumstances that we're involved in terms of practice and how things are going with staying home, working from home, all of those kinds of things. So we'll address those, and also all with the eye of ethical considerations. So we welcome your questions. I love, Sarah, how many folks are emailing in actually, either during or after our chats, and I love seeing those and being able to include those and incorporate those into some of the things that we chat about before we get into the live questions. So what we've tried to do is provide some resource slides. This is a slide from last time. It's in the materials that are posted on the Trust CE training website. And what we're doing today, so that y'all can see more of us and less of the slides, which is basically just a list of our agenda. We're going to show it very briefly, but then we're just going to remove the slides so we can have more of a casual chat about what's going on and the topics that we have and the questions that are coming in. So by way of transition, we'll move into topics related to clinical engagement. We'll review some concepts related to returning to care and some of the ethical considerations of that. Lots of questions on this from last week, so we've kind of woven those into our discussions. Also some appropriateness aspects related to assessment. Lots of people asking about not just how to do assessment during these times and related to the telepsychology approach to assessment, but also with regard to if we're returning to in-office services and what special things we might need to consider for that, and then some other topics related to substance use disorders, etc. So thanks for being here. And with that, I'm going to transition us. Sarah, I know we've talked a lot about aspects of telehealth that are different to in-person, in the same office experiences of providing care. And I thought maybe you could share some of the things that we've chatted about briefly in the background related to clinical engagement and how you do that.
This is a theme I could talk about for too long, so I won't. Oh, and there's our heads in large formats. Nice. Okay, I'm really excited to talk about this theme because, you know, as psychologists, we know that themes of therapeutic alliance, clinical engagement, and rapport, these are interconnected themes, and they are so central to effective therapy. And I'm not going to belabor it, but we know there's good research that demonstrates that good clinical engagement will improve our outcomes. It will reduce attrition in therapy. And generally, you know, it will just improve the experience therapeutically, both for client and for provider. And so, you know, generally speaking, there is a good literature. I think there's a very interesting divergence in the literature that generally speaking, clients tend to rate rapport in telehealth highly, with this being compared to in-person conditions. They tend to rate their feelings of clinical engagement with the I'm operationalizing clinical engagement very much in terms of therapeutic alliance and in terms of rapport with the therapist, although there are diverse ways we could operationalize this. But there's a good research literature that says that clients tend to feel connected to the provider via telehealth. An interesting departure, I think, is that providers tend to struggle more with this. Now, it's not that they rate it low per se, but compared to how highly providers tend to rate it, you know, it's a notable discrepancy in my mind's eye. And I could go on about 100 hypotheses I have as to why. I mean, one thing, I'll say two things. One is that many of us, as we persist in our telepsychology practices, feel some of the fatigue. There's almost a performative quality, you know, to doing care over telehealth. It can be challenging to get that rapport and that alliance. And I think that, you know, this may be one of the reasons that providers tend to rate it less highly. It certainly comes up in a lot of the discussion sections of papers. But then, you know, additionally, I think that when this literature on patient satisfaction came out, it was pre-COVID-19. Now, papers are emerging all the time, you know, but I think a lot of the data that we have is based on a pre-coronavirus world, in which if you were electing to have telehealth, there's a good chance it was either the only option or highly preferential option for you. In-person care would likely have been a choice. If it wasn't, you recognize that telehealth was the way you were getting care, and that, I think, tended to shape clients' perspectives on this. So I do want to acknowledge that a lot of the data, it will be interesting to see what the data says, you know, as we go along and as we collect more information, when we've just had a larger swath of the population participating in telepsychology. I'll be very interested to see what that satisfaction data looks like.
I think it's a really interesting point, and especially reevaluating the psychologist, the provider's perspective, given that a lot of people made this pivot not because that was their desire for practice, but their essential need in order to continue to provide care. And also interesting how many may have been somewhat reserved in that consideration of telepsychology ahead of this, who now actually may be some of the enthusiasts like us, where it just took getting over that transition and trying it out to really see some of those components. I think very similarly, there's probably a few who might have been really thoughtful and thinking this would be something they wanted to do, but now after being on screen for 40 hours a week, it just might not be their cup of tea.
Absolutely. I mean, I think this is going to be a time of self-discovery in the telepsychology world. And, you know, when I think of those foundational skills that we learned in graduate school, if I take it back to those first semesters, you know, of psychology school, you know, we learned things like how we engage a client, how we establish rapport with things like make eye contact, Be thoughtful of your body posture and mirror and show up physically. We learned things like affectively matching the client when appropriate. We learned about being sure that we're reliable, that we are professional, and that we have clarity, that we speak clearly, that we emote clearly, that we're not obtuse, in session. And I think about all the impediments inherent to the modality. It is challenging to make, gaze is the biggest issue. We know that when I look into the camera, I appear to be looking you in the eye, but if I look at where you are on my screen, my gaze may be downcast, and it's a weird experience. It gives people a different sort of interaction, with the clinician. And so too, I can back way up off the camera and put more of myself on the camera, but there's still some limitations. Now, I actually will say when I do my clinical work, I back way off. I actually angle it in another position, and I probably sit in about in the middle of the room. But even when I do that, you lose some things. You don't see the emotion in my face with the same clarity. There are times at which there's disruption in the technology. I'm not able to be as reliable. When I'm working in my home office, it's pretty obviously a home office. It's not my professional office. So I think it does reduce some of the professionalism inherent to when you see me in my lovely office with shaggy throw pillows and a leather chair. I think there's a little bit different, in this milieu. And so I think that we are experiencing some unique challenges in how to really show up in the same way and really engage our clients and establish that rapport in the same way. That really goes back to therapy 101.
And I would just kind of tag on to that I really find at this point that the clinical interview skills are some of the things that I'm really, we've honed and crafted over the years of practice, where there's things we'll pick up on in behavioral observation in the office that we might not ask about yet. Now I'm not getting that behavioral observation and really reminding myself of going back through and asking about a lot more. And this is a convenient excuse because I can't see, or it wasn't clear, or we had a jitter in the connection. But it really is a way to have a different type of connection and a different type of I guess, rapport building with clients that in some ways I think is something I want to remember if I ever pivot back into my office, that I can still really draw in and have a deeper rapport building if I start to really articulate some of those pieces too.
There's so many things we can do, and there's the role of levity and the role of candor, but I think there are these moments that we have to stop and just really slow it down. I'm using more structured clinical interview questions. I'm using my SCID-5, I'm using other diagnostics, sometimes formally, sometimes not, but just to remind myself to ask about the full spectrum of clinical indicia that I take for granted when I can see you. And, perhaps I rely too much on those observations and my assumptions, that belie them. An example I often use, and perhaps I've used it here before, stop me if you've heard this one before, is that if a client is in my office, and looking away, I'm going to make some assumptions about their affective state. I'm going to wonder if they're engaged. I'm going to wonder, if they're concerned. Now I'm wondering if they're looking at their phone. Are they responding to someone outside the door? I think it's a greater diversity of cues that I'm trying to be thoughtful about. I generally try to cultivate the habit. There's some little behavioral things that I'm doing to try to, make it as normal as possible. I do stare into the camera from time to time. It's a totally weird thing to do because I cannot see the client that well at that time. I'd like to train my eyes like one up and one down, like the Madagascar chameleon. I am backing up off my camera to have more physicality and try to show up in that way. I actually wear a suit jacket on days I do therapy because it lends itself to a certain professionalism. I have to think about, there's some populations I've worked in that would not be helpful, it would not help rapport, and some it would. I think I'm from very rural Ohio, and if I went home to Ohio in some of the communities I grew up was wearing a suit jacket, I think folks would just kind of shake their head and be like, okay. But I think that I'm trying to get an office space that doesn't have too much disclosure and that sort of is matching affect. So, actually, I don't often see clients in this austere a background, though sometimes I do. And sometimes I have a different orientation where you can see, a chair and a cabinet. You can't tell necessarily what type of room I'm in, but it feels a bit homier. It feels a bit warmer. I think it is better aligned with sort of how I like to show up affectively and clinically. The environment, I think, better matches what I'm trying to communicate. And it helps clients make good choices about their environment too. It sort of models some of the things to maintain together. So I think that there's this opportunity to be thoughtful about what we can do. And the final thing I would mention is affect in one's face. Whenever I was training folks in telehealth back in the day when this was what I did for my job full time, my first thing I would do would record you and just have a brief conversation. The person and I would record them and I would show them the recording. And I think many folks were surprised, myself included, when I first did it, about the discrepancy between the affect they were intending and what was showing up on camera. And the example I like to give is if I were speaking to you like this, interpersonally, this would be an absolutely normal way to be speaking. I'm not blunting my affect necessarily that much. And it's really different than when I'm speaking like this. And again, you're going to have to decide what feels right for you clinically and what feels like how you usually are. I think in my early days, I attended a training in telehealth that said I should bring 110% of my usual emotion to my face. And I'm not sure how we quantify that, but I think there was something to it. And I think there's something about bringing more animation to our face and to the upper part of our body. I'm a terrible hands talker, so maybe not quite so much of that. It's distracting, but I think just trying to show up in ways that we can and in ways that are available to us help establish that rapport and that engagement and hopefully, bring us along, in forming that alliance, even in this milieu.
I think you hit upon a number of aspects that folks are learning on the job. There's this whole other component of we also see ourselves, right, in the video conference, whether we're smaller or sometimes on speaker view, I'm seeing me. But all of that said, we're getting a lot more of the video feedback and having to work harder in terms of our facial expression, in terms of kind of keeping tabs on time and on what we're showing on our screen. And it just, from a provider standpoint, if you're not or haven't been used to a lot of online engagement, it's definitely one of those areas that I think with all that sensory input coming in is one of those areas of fatigue. And you're also having to put a lot out in terms of that emotive quality. So maybe we appreciate actors more in terms of it really is a hard job. But I think just thinking about all of those pieces combined, it really calls for making sure you do have enough breaks in between clients and are doing a lot of self-care in this world of online telepsychology practices.
I know there are some things people are doing to help attenuate some of the strain, some very snazzy blue lens glasses I've seen, as you say, arranging their schedule to either not have as many stacked up clients in a day. I know I've actually spread my schedule out. I used to only see clients 3 days a week and they were pretty long days. And now I'm seeing clients 5 days a week because it allows me to have a shorter day, which I feel makes me more present. I'm scheduling breaks in between to get up and walk somewhere, drink some water, do something. But the fatigue is real. And I guess the other thing I would just like to say to everybody joining us is like that we could just hold it with compassion because this is hard. And with everything else going on in the world right now, these are hard and thought-provoking and important days, and just holding it with compassion that we have a job that's hard and that if we're feeling the fatigue, that's okay, maybe that's right where I'm supposed to be, and if I can hold that with a lot of kindness and compassion to myself, and take good care of myself, maybe I'm better positioned to take care of others and take care of the world.
Awesome. I think some wise and sage perspectives. So I do wish we had those 3-day weekends still, but there they go.
A lot of questions about returning to that in-person care. That's really top of mind for lots of folks. And Mario, I'm eager to hear some of your thoughts. I know this is something we've been chewing on together a bit. I'm eager to hear what you have to say, particularly in light of some of the sort of insurance concerns and regulatory concerns I'm eager to hear from you.
Yeah, so, in a lot of the questions that we received last week and some written in, and I made some notes of some of the specifics, but I think we do need to think about this in terms of several aspects as we're considering any of these questions. And it's partly about the provider, it's partly about the patient, it's partly about insurance carriers, if that's a piece of things, and it is also a large amount about the regulatory realm. So one of the questions we received was, an insurance carrier has informed folks that they would no longer reimburse telepsychology sessions after June 30th for either telephone or video conference. And the provider is saying they're not wanting to return to in-person care for their own health reasons, and asking, what kinds of things should we consider, what could be done here. And I think this is such an interesting question, because it's certainly on all of our minds. Like, it took a while to get to, oh, we're just going to do telepractice, but now it's like, oh boy, insurance required, or excuse me, in some jurisdictions, the regulations were requiring insurances to cover those services just as they were for in-person. And so those kind of limitations now have, and the restrictions for those are now coming back into play. And so the executive orders are expiring. The insurance companies are saying, hey, we don't have to follow that anymore. And, I guess seeing the benefits maybe of how this has worked and providing care. And so we've got a circumstance where, and it could be, in this example, it was the provider, but it could be that it's not okay for either the provider or maybe the client to return to in-person care. And I think in any of those circumstances, the number one recommendation I would make is getting on the phone, the provider with the insurance carrier, to talk through what are some of the challenges that are ongoing. And if it's your own health circumstance, you're probably going to need to disclose that to them, that it's not something that you're able to do to return to care within an office setting. If it's a circumstance that your office building isn't open yet, that might be a whole different thing to share. If it has to do with immunocompromised factors for your patient, those are going to be some things that you probably are going to need to have discussions about with your insurance carrier to see if you can work something out with them. There's certainly an appeals process for claims that are denied based on those circumstances, and you're going to want to ask what those processes are and how you follow those. And I would encourage your clients as well to make sure that they're contacting their insurance provider to get information. Sometimes what the clients hear from the insurance carrier and what you hear as the provider from the same insurance carrier may not be the same information, because you're actually calling two different parts of the insurance company. And so, there's a lot of information to make sure that we are having time to find out and making sure we have time in our schedule to do that. In this circumstance, you may also want to reach out if you have colleagues who are also experiencing some of these things, or contacting your state psychological association to see if there's some lobbying or advocacy that they may be doing. And you're also going to want to really review what those executive orders have been that's been in place, and when or how those might be changing, and what those timelines are. Because you may find out something, as colleagues in my area did, where the insurance company was not interpreting the information correctly, and that in fact they did indeed have to comply with the insurance commission requirements to cover parity with those in-person care. So there are some resources that you have available, but it takes time, and it takes scheduling that time to figure it out and having those conversations with your patients.
It's a great point, allocating that time to have these conversations, because I think in many ways, these are very unprecedented concerns. The notion that I would initiate care with someone and then shortly thereafter have the expiration of an executive order that had allowed the care in the first place. Let's say I was, doing a temporary practice across state bounds, or let's say, which again, we should only do if there's very explicit and that nice ASPPB COVID-19 resource that tells us where these types of things can happen. But let's say something like that happened, or I began therapy with someone and it was via telehealth. That was how they want to be receiving care. It was covered by their insurance. And then here, lo and behold, months later, weeks later, it is not. I mean, for me, it brings up themes of ethical abandonment and, ensuring we're providing care to patients, but then simultaneously, being thoughtful about the regulatory circumstances and, the financial circumstances of it, and figuring out how this all works well and works well in a framework that is ethical and prioritizes patient care.
I think for me, Sarah, it really hits upon this importance of both having obviously some consent forms for your telepsychology work. We've talked about that in many of our other chats and our webinar series. But as we're returning to inpatient care, we also are now needing to have some returning to care or in-person care addendums. And it's not how it was before. We need to really consider what are the aspects of if this were to happen again, and how might services change, and they might change very quickly again if we are returning to care and we have another wave or another executive order. And so we need to be phrasing these things and having these very transparent conversations with clients, that it's not simply that we're just now doing video conferencing or telepsychology, that this may be an uncertain path that we're engaging upon, and we don't know if that will be covered. We're not able to make those decisions. That's the insurance company, if it's a third-party carrier. If you don't take insurance, obviously it's a little different situation and scenario. You're free to kind of have those discussions more individually with each of your clients. But I think some of the aspects of returning to care has to do with, are we returning for everybody? Are we kind of deciding who we can return to in-person care with? Are there certain aspects of what we do in our practice that make more sense to return to in-person care versus maybe reducing the overload risk of having, everybody back in the office? Maybe it's only the assessment patients, for example, that are coming back to the office. And that's one of the things that we've discussed a lot in my private practice, is who is coming back in. We're able to open the doors again. Does it make sense for everybody? No. Do we want to spend a lot of time cleaning and sanitizing everything in between a full caseload for 4 providers? No, we don't have that time. What are the timelines that we have, and who's the priority in that regard, in terms of both who's maybe been waiting the longest, and or the services that are the most in need of returning to in-person, in-office care. And I think tons of questions we've had about assessment, and the really big challenge of doing any type of standardized, reliable, valid assessment using methods that were not standardized or assessed in terms of a video conferencing platform. And really thinking about those being the cases that may be the first to come back into the office. What do we need to do? Do we still administer those in the same standardized format, or are we putting up a plexiglass shield and sliding things underneath, and not having patients bring their own pens and pencils? Like, what level are we working at here? We've had questions about, well, our service is different with masks on and masks off, and some states are mandatorily requiring the masks if you're in a clinical setting or certain hospital settings. And do you make that judgment in terms of your own practice setting? You have to go by what your public health department is recommending, and sometimes that's different from the state level to your local community level. And so, you know, you have to really be able to articulate all of those aspects in terms of that addendum of returning to care. And I love that the trust has given us a nice template to work from with that.
Absolutely. I definitely feel like we're each of us working with this amalgam, you know, what our local jurisdictional rules suggest, where we live within the state. I live in a county in Washington state where the stay home phase was extended while, you know, many other counties were not. And that makes sense because we're a more population dense place. You know, and then I'm looking at the guidance that we received from the trust, you know, and some of their recommendations as we return to in-person care. If you haven't checked it out, anyone who's watching, you know, I'd say go ahead and check it out. It is really excellent, inclusive of, as Margot mentioned, a template for informed consent for returning to care. And then, you know, additionally, just what works. I mean, I took a tape measure into the office that I'm a part of and measured, you know, could we get 6 feet between client and practitioner? I wanted to make sure because some of the offices were smaller. And so do we need to rearrange the furniture? I took chairs out of the waiting room. We taped over, actually, I should say, my colleague and I did this. We taped over, you know, things. We made sure there was hand sanitizer, you know, just all these things that they're the practicalities, you know, we're using masks. So we made sure there were masks, you know, and it took a lot of advanced planning. I had to find masks on Amazon, you know, and it took planning to get everything in place. So I think, you know, it's a good point. Again, allocating the time, you know, because it took a minute to think that through and to think it through before the stay home order expired and make sure that we were well positioned and that we had thought through the issues. Like, do we want the plexiglass? You know, do we want the mask? Do we want the hand sanitizer? You know, when we did, you know, and doing our best and figuring that out.
And, you know, I think you can say all of that, but the practical process of how do you do all of that
Yeah.
is a whole other layer. And, you know, as a business owner, it's a bit different than as a non-business owner in the same setting. But there are procedures, and really documenting those and operationalizing those so that if you need something to fall back on, you've got an office policy, you've got a plan in place, and that helps the providers there feel comfortable. It also helps the patients coming in feel comfortable. And if they don't like what's outlined in those procedures, well, then those are discussion points as to, well, maybe now isn't the time to be returning to that in-person care. So many, many things to think about. And I think, Sarah, you really brought up a big highlight of, if you have been providing services for folks that haven't been able to come into your office because they're actually in a different jurisdiction, and you know, they're choosing to stay home even if stay home orders have been lifted because of, you know, their immunocompromised position, many of us may no longer have the option to have that practice continue, simply because the jurisdictions themselves the legislatures haven't enacted laws that have been able to support what the executive orders have put in place. And so
License.
yeah. And, you know, I think it's really easy to kind of blame the licensing board because, you know, they're not letting you do this, but they can only do what they do because the legislature gives them authority to do that. And that, if you're really looking for a place to, you know, get your voice heard on some of these issues, it would be contacting your legislators.
That's a great point.
So just a small plug there. You know, maybe this is a good transition, Sarah, to talk a little bit more about telehealth services and kind of some of the fit for who's a good candidate. You know, we've pivoted, but we don't necessarily want to continue on in teleservice with all of those patients, and or we have some decision points here. So maybe you could speak a little about that.
Absolutely. And we received some great questions about this over the past few weeks. And so I know, Marga, you and I picked out a few to talk about.
Yeah.
Quite a few questions about this goodness of fit issue. So how specifically would I assess who could be a good fit for my practice? And I do want to acknowledge there are some specific measures out there that I think are really great. The ASH 25 is one I like very well. The place that I know that it's published is in a book by Peters, Shore, and Turk. So Peter Shore and Peter Turk both edited a book, and I believe it's actually in a chapter that Peter Shore wrote. This is his measure that he developed called the ASH 25. So it's, if you were looking for a formal measure, you can find the ASH 25. I've actually developed one, and folks were dying for a copy. You're welcome to contact us at the email we'll show at the end of the presentation. But to date, there really are not many data-driven exclusions. And by that, I mean, you can find papers that cite, considerations. So for example, clients' vision, clients' hearing, clients' stability and probability of an emergency. Specifically, if they have a diagnosis of something that heavily involves avoidance. So someone has agoraphobia or panic attacks, there is something to be said about coming into the office when it's safe and healthy to do so, when it's appropriate for both patient and provider. If someone had ideas of reference or delusions around recordings, cameras, things like that. So we could find discussions of these matters, but at the end of the day, there's not as though there's some codified, data-driven reason of, we never see clients with this concern over telehealth that I am aware of. There's a paper I think I really like by David Luxton, I believe it's one of his 2012 publications, that talks about saying, well, you may want to think through themes like your own capacity to manage an emergency and that client's emergency history. Is this within your scope of practice, your boundaries, your practice? And to me, that's really often what it comes down to is, there are things that we'll want to consider, some of the things I've just hit on: access to care, clinical characteristics, clinical stability. At the end of the day, though, it has a lot to do with what you want to do. And I think that I deeply believe, we need to practice within our scope, and that's inclusive of what services we feel competent and comfortable providing. So, if it's a brand new therapy and I've never, seen a client before and telehealth is brand new to me, it might not be the way that I really want to kick off this new therapy. I don't want to just necessarily start two new things at once. I mean, you could, but I think my encouragement would be think about your own boundaries and go slowly. If you want a formal measure, feel free to email me. Mine is, not psychometrically tested. If you want a published measure, the ASH 25, I think is great. We also, speaking about scope and like whether folks were comfortable delivering this service or that service over telehealth, we received a few questions about substance use disorders, or SUD, over the last week. And I wanted to take a few moments to talk about some of the considerations specific to substance use. I think most prominently for me are themes of reporting. So, is there sometimes, I know SUD is an area I've worked in a lot in my career, and sometimes folks come to see me because they're just really invested and they're ready, to make a change. Sometimes, they're there in a court mandated situation. Maybe they're also ready to make a change, and maybe they're not, but they were required to come see me. And in those circumstances, there may be reporting that I'm doing to some sort of legal office, whether it's an attorney or whether it's a parole officer or something, having to indicate their completion of therapy, as well as in a partner lab, urinalysis, breathalyzer, or other measures of proximal use. So in those circumstances, it gets a little challenging because particularly folks have been saying, well, wait a second, how do I get urinalysis? How do I get breathalyzers?
That seems easy to do in a telepsychology atmosphere.
Hard. I'll say that, when I've done this, I've worked in places that had a lab, where that was done. There are options. I know of some colleagues who are still working, many labs are open, so you can go get a blood draw still, you can get a test for this or that. And oftentimes they'll have a relationship with a local lab where the client can go and leave a sample, for whatever needs to be reported on, if it's some sort of legal, mechanism. I'll be honest, in my practice right now, I have very limited reporting requirements. And so oftentimes I'm having folks do home-based tests. Could they, trick them? Of course. But they could have tricked them otherwise, but if it's something that they feel for their accountability is working for their treatment plan, we're going to keep it in a way that keeps them accountable. But that's a very different thing than if I had legal reporting or something like that. And I do want to give a particular mention to medication-assisted treatment for opiate addiction, because there are some specific considerations, particularly if anybody is, in addition to being a psychologist, if they have prescription privileges in their jurisdiction. Sometimes that's facilitated for psychology, some jurisdictions it's not, but usually there's some additional training and education. For folks who have that, I do want to mention that there are specific considerations for medication-assisted treatment for opiate addiction. But there is also very good literature for people delivering care via telehealth this way. So it is not something that's contraindicated. There are specific, I would point you to the Ryan Haight Online Pharmacy Act, in that, you know, they're very thoughtful about when we're crossing jurisdictional boundaries, but generally speaking, we're very thoughtful when we're crossing jurisdictional boundaries. So it's not that novel, but there's some additional considerations, especially when prescribing controlled substances, which are sometimes involved in medication-assisted opiate therapies. So those would be my major SUD considerations that I would want to mention.
Well, I think overall, it really comes down to how you're viewing your practice as a provider, how much bandwidth you have to take on what level of severity of cases, and really thinking about, you know, if you're working from home or working in the remote methods, even if you are in your office, that there is extra drain and strain in terms of that practice setting, and making sure that you're scheduling enough time in between to give yourself the break you need to recharge and regroup, and or make some phone calls to some of the extra components of care that might be involved in managing the billing and the kind of background paperwork side of what
UA lab report is not always easy.
Exactly. So I'm thinking at this point, Sarah, it might be worthwhile to just looking at the time to transition to some of our live questions.
Yeah,
I know you've been keeping track of some that are coming in, and we still have a few that came in last time that we can certainly chat about as well. So
absolutely.
I know you have your eye on those, so I'll kind of turn it over to you.
That is, let me get it right here. Okay. Any suggestions about how to be HIPAA compliant in receiving client payments via bank transfers, which minimizes or completely avoids a fee for licensed psychologists?
Oh, what an awesome question. And it's a theme. We actually had one of those questions, actually several of those same kinds of questions of what to do with how to get payments when you're not in the office. Of course, the same old-fashioned approach works. They can send you a check, but if you're not in the office and you're not there picking up your mail, I guess that could be one challenge. As I understand it from the trust risk managers, any of the online banking apps like Venmo or PayPal, they all have to follow the same secure banking requirements that our banks have to follow.
Right.
Now, there's certainly folks who'll say, well, that's not the most secure, and there's, you know, factors related to all of that. There are service fees associated with those, no matter how you go about it, because you have to pay for that service. And I think the question that came in was, is there one that doesn't have a fee? I don't know of any that don't have a fee in that way, because somebody has to pay the service fee. Something like Venmo, it would be the person paying you is paying that service fee, so you don't lose that necessarily. But you do have to be careful with the difference between a personal Venmo account versus a business Venmo account, and you want to read the details of what those requirements are, because once you enter, they define what the personal, you know, who you can accept as a personal payment versus a business payment.
I agree, and I would add that, to my understanding, and correct me if I'm wrong, I believe the HIPAA rules, including business associate provisions, do not apply to banking and financial institutions. You know, so we are really allowed to use, and I know bank transfers keep coming up quite specifically as an area of interest, but my understanding is we are allowed to do this. I tend to, as you said, Margot, I like the ones that are non-public facing. So Venmo is a nice example of one that is not, to my knowledge, for the personal accounts, not assessing fees, but there's this history of your transactions posted. So you carry your money. I believe you can configure it to be private, but that takes a little doing and some know-how. And so one thing I don't love about some of these formats is it's very transparent on who you're making payments to, which I guess if it's for babysitting or, you know, a new pair of shoes from a friend, you know, don't know why I'm buying my shoes for my friend, but I am, that is a little less problematic than if I'm paying for healthcare services.
And I think there is an issue related to a business relationship versus a personal relationship with Venmo. I have heard that from other businesses, not in psychology world, but in general, that you need a business account and then they do take fees on that. So it's worth looking into and really reading the fine print and not just scrolling through and clicking. But I have heard the same as you, Sarah, in terms of the HIPAA requirements related to not needing a BAA for a bank.
All right, should I give us another one?
Yes, let's do it.
What is the best site, exact link, I picked this because we can do this, to find out if telehealth is allowed for an Illinois psychologist having a telehealth session for a client temporarily in Washington State and Michigan State? Now, I want to acknowledge that we often can't answer every specific jurisdictional issue, but I can tell you the website that can tell you this answer. When you go to our resource slide, you will see, I believe, the website for ASPPB. Is that right, Margot? Am I making that up?
Yes, it is on there.
Good. And there's the COVID-19 section. They do a COVID-19 resource section. They really do a lovely job of going through the different provisional executive orders and temporary licensure rulings in the 50 states and Canadian provinces. And so I think it's a nice resource to go through and you can see the exact answer to that question.
I will also add, in addition, that you can go to the other resource site that we have listed, which is the CSG, I can't remember the dot whatever, it might be .org, but that's where you will find the executive orders, and they're actually organized in multiple filters, so you can see the ones expiring and how that might relate to the question of what you can and can't do interjurisdictionally at the moment.
Mm-hmm. I have a really tricky one. Do you want me to read a tricky one?
Go for it.
All right.
It's like stump the, the chat. Okay.
I think I know the answer. We'll see.
Right.
From an ethical perspective, when does the therapy session start, especially if we're having trouble connecting due to technical problems? For example, we send the client the link at the appointment time and we have trouble connecting for several minutes. How do I build a session regarding length of appointment? If you don't mind, I'll give mine because I had the chance to read it before you did, so I got a chance to read it.
You already got advanced thinking on that. Go for
I
it.
got like an extra minute on this. Here's my thought. I treat it very much, so with regard to the session starting late, because that's the most common occurrence that, for various reasons, people are late to my appointments all the time. I treat it pretty much like the moments that we have therapy, like the number of minutes we have therapy. So I really try to think of an analog being if someone was just late, if traffic got them, or if they were, just late for whatever reason, and they didn't get there till 15 minutes after their hour appointment. The reality is, now, I should say for insurance, I'm going to make a distinction between my private practices and then insurance purposes. For insurance purposes, I can only bill for 45 minutes of therapy is my best understanding. So it would be a 90834 instead of a 90837, that 45 minute instead of 60-minute session. That being said, I may have practices that I have in my informed consent document that say, well, hey, if you're running late, then you are still expected to pay for the entire hour and you may be accountable for some portion above and beyond, when you're late. And that's something I would put in my informed consent document and talk with the client, at the time that we were initiating care. I do want to say though, things happen and technical problems happen. And I've certainly had sessions where it drops and it's interrupted and it's problematic. And I think it is often so difficult to tell where the problems are coming from. So I will say in my informed consent, again, I do say if we are having technical problems, we will switch over to a different platform. So if there's a problem with one video conferencing platform, we could switch to another. If there's a problem with their computer, we could switch to their mobile device. Or if nothing's working, we could switch to their phone, acknowledging that phone will reimburse at a different rate than video conferencing. And again, these are things I talk about, in advance. But if it's just not possible to tell where these problems are coming from and it is just consistently interrupted, then we're going to have to make a decision. Again, my informed consent will generally say that, if it is your technical problem, I'll ask you to disclose that and you would be accountable for the cost. However, I'll let you reschedule it for free. So if your internet is just out, yes, you're accountable for the hour, but I'm going to let you reschedule it. And I'm going to be very lenient about it. Other people have different policies. I'm not saying that's the policy, anyone else would have to have. That's how I handle it. And I'll be truthful. If it's my technology and I know it, this can be very difficult to discern. Of course, I waive any fees. And often, if I know it's my technology, I have even, and I'm not saying anyone should do this, but I've offered complimentary sessions when I know it's my technology and it's something on my side. That's my own weird attitude toward it. Not saying anyone else should. How about you, Marga? What do you think about this one?
I guess I have been very fortunate that, things tend to go fairly smoothly. But in terms of having those discussions ahead, just as I would with in-person, we start on time, end on time. There are certainly times, by the way, where sometimes sessions run long. You can't just leave a session before because, you're in the middle of a really, perhaps detailed discussion in terms of, a suicide risk plan, et cetera. So, my patients know this ahead of time, and definitely we've talked about the same things that you've talked about in terms of setting up how we might get in touch if we happen to be disrupted. What kind of leeway. I tend to be pretty lenient in terms of that. If we're getting to the 15-minute mark, well, we'll probably have some more discussions at that time, or I'm calling them to see what's going on. But I think in general, unless there's been some other type of contact, I do tend to assume that maybe it is technology being what it is, or someone's power's out, or, it's sometimes not even the Wi-Fi, right? But try to figure out that plan ahead is always good, and being transparent on that.
Well, I'm noticing we're at about 5 till. So is it time to put our fancy slides back up and talk about some of the resources there?
We sure could. I just was thinking one last very quick thing that we got that we could kind of talk about just as we're pulling that up. And that was a question about, somebody asked the question about terms of service and privacy policy templates for their website. And of course, as we're moving into a lot of online services, anytime we're doing some of these things, if we have a website, from a HIPAA requirements policy standpoint, we do have to list all of our HIPAA forms and all of that on our website. So I think this is where the question's coming from. We need a terms of service for what type of data we're collecting, and a privacy policy for all of that. And actually, it can be all included into your privacy policy in terms of your practice, can be inclusive of your website. And in terms of service, sometimes there are templates there in terms of from the HIPAA guidance templates that we have, and keeping them simple and readable is my biggest suggestion, because the folks that are looking at them, they're going to click through unless they understand them. And we all do this, right? You get a new app on your phone and it's like, yeah, whatever. And then you realize, oh, Facebook is collecting all this information from you. Oh, why? Well, you did approve for that to happen, but it's because we didn't read the hundreds of pages of terms of service and use. So you want to make those things available to folks.